Hey there, future doctors. Welcome back to our USMLE Step 1 Prep series. Today, we're diving into a complex case of a 32-year-old man with cough and hemoptysis. Let's get started. A 32-year-old man comes to the office because of a 1-day history of cough productive of small amounts of blood and a 2-day history of shortness of breath and swelling of his ankles. He also has a 2-week history of progressive fatigue and episodes of dark urine. He has no history of major medical illness and takes no medications. His temperature is 37 degrees Celsius, pulse is 90 per minute, respirations are 18 per minute, and blood pressure is 175/110 millimeters of mercury. Pulse oximetry on room air shows an oxygen saturation of 91%. Diffuse inspiratory crackles are heard over all lung bases. There is 2+ pitting edema of both ankles. Results of laboratory studies are shown. Hemoglobin is 8.9 grams per deciliter. Hematocrit is 27%. Serum urea nitrogen is 55 milligrams per deciliter. And creatinine is 2.9 milligrams per deciliter. Urine RBC is 20 to 40 per high power field. Urinalysis shows dysmorphic RBCs and rare RBC casts. Kidney biopsy reveals crescentic glomerulonephritis and linear deposition of IgG along the glomerular capillaries. This patient most likely has antibodies directed against which of the following antigens? The options are collagen, double-stranded DNA, nucleolar protein, phospholipid, and proteins in neutrophil cytoplasm. To answer this question, we need to piece together the clinical presentation and lab findings to arrive at the diagnosis. The 1-day history of hemoptysis, 2-day history of shortness of breath and ankle swelling, and 2-week history of fatigue and dark urine are key. Vital signs show hypertension with a blood pressure of 175/110 millimeters of mercury and tachycardia with a pulse of 90 per minute. Physical exam reveals inspiratory crackles and 2+ pitting edema. Lab findings indicate anemia with a hemoglobin of 8.9 grams per deciliter, elevated serum urea and creatinine, hematuria with dysmorphic RBCs, RBC casts, and crescentic glomerulonephritis with linear IgG deposition. This clinical picture is consistent with Goodpasture syndrome, which is characterized by the presence of antibodies against the glomerular basement membrane. These antibodies target the alpha-3 chain of type IV collagen in the glomerular basement membrane. Antibodies against collagen are seen in conditions like systemic sclerosis, but not typically in Goodpasture syndrome. Anti-double-stranded DNA antibodies are a hallmark of systemic lupus erythematosus, not Goodpasture syndrome. Anti-nucleolar antibodies are associated with systemic sclerosis and other connective tissue diseases, not Goodpasture syndrome. Antibodies against phospholipids are seen in anti-phospholipid syndrome, which leads to thrombosis and pregnancy complications, not glomerulonephritis with hemoptysis. Anti-neutrophil cytoplasmic antibodies are seen in vasculitis conditions like granulomatosis with polyangiitis, not Goodpasture syndrome. The correct answer is antibodies directed against collagen. This refers specifically to the alpha-3 chain of type IV collagen in the glomerular basement membrane, which is targeted in Goodpasture syndrome. And that's how you analyze a complex USMLE Step 1 question on renal and respiratory pathology. Remember, understanding the pathophysiology behind the symptoms and lab findings is key to making the right diagnosis. If you enjoyed this video, please like, subscribe, and hit the notification bell for more exam-crushing content. See you next time.